Hello. We are going to now talk on this podcast about the maternal physiologic changes of pregnancy and especially emphasize the anesthetic implications of those changes. So, pregnancy does produce profound both anatomic and physiologic changes. As a result, when you're caring for a pregnant patient, these patients are different from non-pregnant patients. Now, some of these physiologic changes are also actually beneficial to the mother and probably developed evolutionary-wise in order to help women survive childbirth. On the other hand, from an anesthesia standpoint, many of the changes that occur place the mother at increased risk of harm when she undergoes anesthetic procedures. So let's begin by talking about cardiovascular changes, and some of these changes will begin as early as 5 to 8 weeks gestation. Blood pressure actually during the first and second trimester will decrease. And so actually when a woman presents for her first prenatal visit, oftentimes her blood pressure is lower than what her baseline was before she was pregnant. Now, once we get to the term, usually the woman's blood pressure will return to her non-pregnant baseline. So sometimes patients may have undiagnosed chronic hypertension, for instance, and when they initially presented, their blood pressure was within normal range because of that drop that occurs during the first and second trimester. But by the time they get up into the third trimester and towards term, the blood pressure may start to rise, indicating the presence of undiagnosed chronic hypertension. And it can be a challenge to determine whether this is pre-existing or if it is pregnancy-induced hypertension. Systemic vascular resistance decreases by about 20%, and there's a significant rise in blood volume of about 35%. Now, with that increase in blood volume, you may think that your central pressures, CVP, pulmonary capillary wedge pressure, would be increased in pregnancy, but in fact, they should be unchanged. And this is due to the fact that although there's increases in blood volume, there's significant dilation of the pulmonary and peripheral vasculature. So if you see a woman with an elevated CVP or wedge pressure, that is pathophysiologic. It is not a physiologic change of pregnancy. Other changes that occur, most importantly, is that there's a significant rise in cardiac output throughout pregnancy. During the first trimester, you'll see about a 30 to 40% increase in cardiac output. Further rises occur during the second trimester, so that by the end of that trimester, you'll see about a 50% rise in cardiac output compared to the patient's pre-pregnancy cardiac output. Now, the rises in cardiac output occur predominantly as a result of increase in volume. Stroke volume increases anywhere from 25 to 30% during pregnancy. Heart rate does increase somewhat, though, about 15 to 25%. So you see an increase in both your stroke volume and heart rate, but the increase in stroke volume plays a greater role in the increase in cardiac output. So those are the changes in cardiac output that occur just as a result of being pregnant. Now, when you get into the labor and delivery process, there will be even further rises in cardiac output. And this is why the labor and delivery time period can be especially crucial, for instance, for those patients who have underlying cardiac disease. During the early first stage, someone's 2-3 centimeters dilated, you'll see about a 10% rise. During the active phase of labor, now 5-6 centimeters dilated, you are going to see about a 30% rise above and beyond the 50% rise seen just as a result of pregnancy. During the second stage, when the patient is pushing, you'll see like a 45% rise in blood pressure, in cardiac output. And then in the immediate postpartum period, this is an especially crucial time for that patient who has underlying cardiac disease, because with the autotransfusion and involution of the uterus that occurs during this time period, there can be as much as an 80% rise above and beyond that 50% rise in cardiac output. Now, the cardiac output changes that occur during labor result both from an increase in stroke volume due to an increase in venous return, as well as systemic nervous system changes. Now, what will happen to cardiac output after delivery? Well, by about 24 hours postpartum, cardiac output will return to pre-labor values, so that immediate postpartum increase that I talked about will slowly decline, so that by the time you're 24 hours out after delivery, you'll have a cardiac output that's about 50% above pre-pregnancy baseline. And then over the next several weeks, you'll see further decreases, so that anywhere between 12 to 24 weeks postpartum is when a woman will return to her pre-pregnancy level of cardiac output. Other changes that occur cardiovascular-wise, you'll see an increase in your left ventricular end diastolic volume, but an unchanged left ventricular end systolic volume. And this results from an increase that occurs in both ejection fraction and contractility during pregnancy. What about on cardiac exam and on echo exam? What changes might you see? Well, it's not uncommon to have an accentuation of a splitting of the S1 sound. Very common for these pregnant women to have a small systolic ejection murmur. You may also even hear an S3 or an S4. And on exam, you will generally see that there's a leftward displacement of your maximal cardiac impulse. You will also see physiologic changes on the EKG, which in a non-pregnant patient would be considered pathophysiologic. Many of these changes in pregnancy, though, are physiologic changes and are not pathophysiologic, such as a shortened PR and uncorrected QT interval. During the first trimester, you will generally see a right shift of your QRS complex, although by the third trimester, you'll see a leftward shift back. You can see some ST segment depression that is not due to ischemia, and it's also common to see isoelectric low voltage T waves in the left side of precordial and limb leads in a normal pregnant patient. So just be aware that it is normal to see EKG changes in these pregnant patients, and you just need to understand which ones are considered physiologic, which are these that are listed here, whereas other ECG changes that you would see would be considered pathologic, and you need to look for a source for those changes. What about on echo? Well, left ventricular hypertrophy does occur during pregnancy, and at term, you will generally see about a 50% increase in the mass of the left ventricle as compared to pre-pregnancy. It's very common for pregnant women to have some mild tricuspid and pulmonic regurgitation. About 90% of women will show this. About 30% of normal pregnant women will have some mild mitral regurgitation. Now, if it's beyond trace to mild, it's moderate or severe regurgitation of any of these valves, now that would be pathologic. That is not due to physiologic changes of pregnancy. But these mild changes that occur resulting in mild regurgitation are due to the fact that there is an increase in the annular diameter of these valves during pregnancy. Aortocaval compression is a very important physiologic change that can occur in the pregnant patient. In the supine position, as a result of the gravid uterus, you'll have compression of the vena cava and to some extent possibly the aorta, and this leads to a decrease in venous return and a decrease in right atrial pressure. And in fact, at term, in some women, when they lie completely supine, the IVC can actually be completely occluded with your venous return actually occurring via the azygate system. You can see some component of aortocaval compression as early as 20 weeks gestation. However, most women, until they get much closer to term, will not be symptomatic because they are able to compensate for this compression by increasing their heart rate and their systemic vascular resistance via vasoconstriction. However, as you get closer to term, in some women, this compensation of increased heart rate and vasoconstriction may be inadequate to accommodate the compression of the vena cava that is occurring. And so about 15% of term parturients, when they lie supine, may develop signs and symptoms of the supine hypotensive syndrome. And these symptoms are going to include hypotension, diaphoresis, nausea and vomiting, lightheadedness, and from the standpoint of the fetus, as a result of the hypotension, the decreased venous return that's occurring, you may have, as a result of the hypotension, you may have an abnormal fetal heart rate tracing due to inadequate perfusion of the placenta. So what are the anesthetic implications of this supine hypotensive syndrome? Well, the one thing that we need to understand is that in a patient receiving neuraxial anesthesia, you now have a sympathectomy on board, and this interferes with the ability to compensate for the aortocaval compression. So I said just in a normal term pregnant women, about 15% will have some symptoms when they lie supine. If you now then provide them with epidural or spinal anesthesia, a greater percentage of them will be unable to adequately compensate for the aortocaval compression because of their inability to increase their SVR due to the sympathectomy that has occurred. And in some patients, especially those undergoing surgery where you have a high level up to maybe T3, T2, they're not even able to increase their heart rate. And so it's particularly important that we pay attention to the risk for supine hypotensive syndrome in term women who are undergoing regional neuraxial anesthesia. We need to do maneuvers to try to avoid hypotension as a result of that aortocaval compression, which means doing adequate fluid preloading before performing the procedure, but especially important is to make sure after completing the procedure that we do not allow the patient to assume the supine position, that you need to have the patient in some lateral tilt to avoid significant supine hypotension. Now let's move on to respiratory system changes. As anesthesiologists, of course, the airway is very important to us. You need to understand that in pregnancy, the mucous membranes are very friable, so you absolutely want to avoid anything nasally. You don't want to do a nasal intubation. You don't want to use nasal airways. You want to do intubations, airways, all via the oral route. I also need to understand that there can be some airway edema that can distort the laryngeal anatomy, and this can occur in any pregnant patient, but in those with preeclampsia, you can see an even greater increase in edema. Also understand that the enlargement of the breast that can occur can interfere with intubation in these patients. That is why we oftentimes will use a short-handled laryngoscope. There are many other respiratory changes going on in terms of respiratory mechanics. You'll see an increase in your diaphragm excursion, but a decrease in your chest wall excursion. Many of your pulmonary functions, though, should be unchanged by pregnancy. So there should be no change in your FEV1, your FEV1 to FVC, your flow volume loops, or your closing capacity. So if you see changes in these areas, you need to understand this is some sort of pulmonary dysfunction and is not due to physiologic changes of pregnancy. There are significant changes in lung volumes in pregnancy, however. This is due both to hormonal changes, primarily due to increased levels of progesterone, as well as mechanical changes. These changes will begin during the first trimester. You can see a 45% increase in tidal volume, about a 5% increase in your inspiratory reserve volume, and about a 25% decrease in your expiratory reserve volume, with a residual volume of decreasing by about 15%. Your functional residual capacity, most importantly, decreases by about 20%. And this is when the patient is in an upright or sitting position. This is caused primarily by the elevated diaphragm that occurs in pregnancy. Now, this, as I said, this 20% decrease will occur in the upright position. When you put someone supine, for instance, for surgery, for a C-section, you'll see about another 10% decrease in your functional residual capacity. Now, your inspiratory capacity is increased by about 15%. Both your vital capacity and your total lung capacity should be unchanged. So again, if you have a decrease in vital capacity, that is a pathologic change. That is not a physiologic change of pregnancy. What about changes in ventilation? Significant changes in ventilation occur during pregnancy. And again, just like with cardiovascular changes, they occur quite early. You will begin to see changes as early as 8 to 10 weeks gestation. And this occurs due to increases primarily in progesterone levels. Understand that progesterone is both a respiratory stimulant and as a result, respiratory receptors are sensitized to carbon dioxide, and so most of these ventilation changes are due to the high levels of progesterone that occur in pregnancy. In addition, the increase in CO2 production that occurs with pregnancy also contributes to these ventilation changes. Important to understand, minute ventilation increases by 50% by the time you reach term gestation. This occurs primarily due to a significant increase in tidal volume. You will see some small changes in respiratory rate, but relatively minimal. Most of that 50% increase in minute ventilation occurs as a result of the increase in tidal volume. Now, this is just with being pregnant. You also need to understand when you have someone in labor, she may start doing some hyperventilating due to the pain of labor, and this will result in even further increases in minute ventilation during labor. There are other respiratory changes that occur. Progesterone also is a bronchodilator, so you'll see reduced airway resistance in the pregnant patient. What about airway closure? I mentioned, functional residual capacity is decreased, and in about 50% of women in late pregnancy, when they lay supine, their FRC is less than closing capacity. As a result, this leads to closure of small airways during normal tidal volume breathing, and so you may actually see a decrease in PaO2, so that you may see a somewhat lower PO2 than 100, although generally it's not going to be lower than about 90 if it's just due to the physiologic changes that I'm reporting here. There is an increase in the circumference of the thoracic cage during pregnancy. However, due to the elevation of diaphragm, there's a decrease in the vertical measurement of the thoracic cavity. Now, we talked about the fact that there's a significant rise in minute ventilation during pregnancy. And so how does this affect blood gas measurements in pregnancy? Well, as a result of that increase in minute ventilation, you absolutely will see a decrease in the PaCO2. A normal PaCO2 in pregnancy is about 26 to 32. So if you have someone with a CO2 of 35 to 40, that is not normal. Although if you got the result back from the lab reporting your blood gas result, it would be considered within normal range. But you need to understand that for a pregnant patient, that is actually a sign that they're beginning to retain CO2. Now, there is a compensatory decrease in the serum bicarbonate. As a result of this decrease in PaCO2, normal serum bicarb in a pregnant patient is around 18 to 21 milliequivalents. So even though there is a marked rise in minute ventilation, there is not a significant development of respiratory alkalosis due to this compensatory decrease in serum bicarb. Normal arterial pH is just minimally elevated at about 7.44 in the pregnant patient. Now, oxygen consumption is increased significantly during pregnancy also, increases by about 20%, and then during labor, you can see as much as an 100% increase in oxygen consumption. So keep that in mind. However, the oxyhemoglobin dissociation curve is shifted to the right, so that will facilitate oxygen unloading to the fetus. Generally, if you think about it, most of your physiologic changes of pregnancy are going to be beneficial to the fetus. So increase oxygen delivery to the fetus by shifting to the oxyhemoglobin dissociation curve to the right in a normal pregnant patient. I will tell you that in a preeclamptic patient, you get a leftward shift back to what's sort of a normal position for a non-pregnant patient. So what are the clinical implications of these respiratory changes? Well, we know as a result of the many changes that occur within the airway edema, the large breasts interfering with the ability to intubate, that there's an increased incidence of failed or difficult intubation. And in various studies, the rate of difficult intubation generally is about 8 times greater in the pregnant patient compared to the non-pregnant patient. As a result of both the increased oxygen consumption that we talked about, as well as the decreased functional residual capacity, pregnant women will develop hypoxemia much more quickly. And you will find that in the normal pregnant patient, if you're inducing general anesthesia, you put her off to sleep, have given succinylcholine and made her apneic. If you're not able to get the patient intubated right away, much more quickly will you start to hear that pulse ox tone go down as she desaturates compared to a normal healthy patient in the main operating room who is not pregnant. Now, because of GI changes that we're going to talk about in a minute, we would not actually do an inhalational induction of general anesthesia in a pregnant patient. However, I have sometimes seen test questions related to the effects of physiologic changes of pregnancy on inhalational induction. And both the increase in minute ventilation and the decrease in functional residual capacity combined to make it such that you would see a more rapid inhalational induction in a pregnant patient. Now, I do know, as you probably remember, that an increase in cardiac output will actually slow your induction time for inhalational induction, but the combination of the increased minute ventilation and the decreased FRC are greater than the effect of the increased cardiac output. So in pregnancy, you would see a more rapid inhalational induction. So in terms of managing the pregnant patient and considering these respiratory changes that occur, what do we need to do to minimize the effects of these changes in our anesthetic management? Well, we need to make sure that the patient is optimally positioned prior to intubation. And there are some that would recommend that you actually keep the patient in a somewhat head-up position during your pre-oxygenation and induction. You need to use a short-handled laryngoscope so that you minimize the effects of those large breaths. As I mentioned before, avoid nasal airways and intubation. You need to make sure that you adequately pre-oxygenate with 100% oxygen prior to inducing general anesthesia. One benefit of the physiologic changes, though, is that increase in minute ventilation makes it easier and quicker to adequately pre-oxygenate. Obviously, you want to minimize periods of apnea also. Now, in terms of these respiratory changes, when do they come back to normal? Your functional residual capacity returns to pre-pregnancy levels in about 1 to 2 weeks. Minute ventilation and oxygen consumption remain elevated to some extent until about 6 to 8 weeks postpartum. Now, gastrointestinal changes, those are also very important changes for us as anesthesiologists. There are both mechanical and hormonal changes that will occur that will result in changes in the GI system. In terms of the mechanical changes, the stomach is pushed cephalad by the enlarging uterus. As a result, this results in increased intragastric pressure. It also distorts the GE junction and contributes to the gastric reflux that many pregnant women experience. In terms of the hormonal changes, the most significant hormonal changes from the GI standpoint is the increase in progesterone levels that occurs during pregnancy. As a result of the increased progesterone levels, you will see a reduction in the lower esophageal sphincter tone and also a decrease in peristalsis. Of note, the placenta does produce gastrin, but it seems that it's not significant enough that it does not clinically affect your gastric acid secretion. So be aware that there's increased gastrin production, but it doesn't seem to significantly affect gastric acid secretion. Now, what about gastric emptying? In the past, people talked about pregnancy affecting gastric emptying. What we know now from various studies that have been done using ultrasound, etc., excuse me, is that pregnancy in and of itself does not affect gastric emptying. However, when you have a patient in labor who is in pain, who may have received opioids, definitely during labor you do see a decrease in gastric emptying. So what are the anesthetic implications of these gastrointestinal changes? Well, first of all, parturients at about 12 weeks and greater are generally considered to be at risk for acid aspiration, so that I feel that any pregnant women beyond 12 weeks gestation should be treated as a full stomach. I will tell you that many pregnant women have symptoms of gastric reflux even during the first trimester. So personally, in terms of making my anesthetic plan, I will consider any pregnant patient a full stomach and therefore will plan an anesthetic that protects the airway. So these patients need to be provided with aspiration prophylaxis, and if they're undergoing general anesthesia, they need a rapid sequence induction. Now let's move on to the hematologic changes of pregnancy. So blood volume increases by about 40 to 45% in pregnancy. Plasma volume increases even more by about 50 to 55%. Red cell mass is increased by about 30%. So the red cell mass is increased. However, we do see a dilutional anemia pregnancy with a normal hematocrit being about 35%. And that is because your red cell mass increase is not as great as your plasma volume and blood volume increases. Plasma proteins are increased in pregnancy, but again, they increase less than your plasma volume. So there's a decrease in your plasma protein concentration and your albumin concentration in pregnancy. Globulin levels are increased by about 10% at term, and your albumin to globulin ratio is decreased in pregnancy. You see a progressive decrease in your colon-oncotic pressure during pregnancy as a result of these changes in plasma protein concentrations. Also, it's important to understand that pregnancy induces a hypercoagulable state. Many of your clotting factors are increased, including factors 7, 8, 9, 10, and 12. There's also an increase in fibrinogen. As a result, pregnant women are at increased risk for DVT and pulmonary embolus, and in fact, pulmonary embolus is one of the leading causes of maternal mortality. There does appear to be some enhanced fibrinolysis with an actual increase in fibrin degradation products. What about platelet count? Generally, your platelet count should be unchanged, or you can see a mild decrease, what we talk about as gestational thrombocytopenia, in platelet count. But if you ever have a platelet count that is clinically significant, it's below 100,000, for instance, that is generally not a physiologic change of pregnancy, but rather you need to look up at a pathologic source for that much of a decrease in platelet count. What about postpartum? What happens in terms of these hematologic changes? Well, your blood volume at about 1 week postpartum has decreased so that it's now at about 125% of pre-pregnancy levels, as opposed to the 35 to 40% increase we talked about before. And at about 6 weeks, it's down to about 110% of pre-pregnancy blood volume. Your hematocrit in the first about 3 postpartum days will decrease, but then will gradually begin to increase so that it reaches pre-pregnancy levels at about 6 weeks postpartum. Albumin and plasma protein concentrations and colon-oncotic pressure will decrease right after delivery, and then will slowly rise over the next several weeks such that you reach your pre-pregnancy albumin and plasma protein concentrations, as well as pre-pregnancy colon-oncotic pressure at about 6 weeks postpartum. You should see increases in fibrinogen and platelet count in the postpartum days 3 to 5, and at about 2 weeks postpartum, overall your coagulation profile should be back to normal. What about central nervous system changes? Well, there is an elevation in pain threshold during pregnancy due to the fact that there are increases in endorphin and enkephalin levels. It has been shown that the MAC of volatile anesthetics is decreased by up to 40% in pregnancy, and this is felt to be both to this increase in endorphin and enkephalin levels, but also due to the sedative effects of progesterone. However, there is some controversy currently about the clinical relevance of the decreased MAC of pregnancy. Remember that MAC is actually a measure of spinal cord responses, reflexes, and it is felt by some studies that have been done recently that although there is a decrease in MAC, that you don't actually need to, that the volatile anesthetic requirements to maintain an unconscious state are not significantly decreased. And this is based on some studies looking at BIS levels in pregnant patients. So remember, MAC is decreased significantly, but this is actually a measure of spinal cord responses. And in terms of consciousness, you actually may not need to significantly decrease your volatile anesthetic levels in the pregnant patient in order to make sure you maintain an adequate level of unconsciousness. Local anesthetic requirements are decreased by about 30% in pregnancy. From a neuraxial standpoint, part of this is results from the decreased volume of the epidural space that occurs due to the fact that epidural veins are engorged in pregnancy. As a result of that decrease in the volume of the epidural space, there will be greater segmental spread of your local anesthetic. In addition, it's also been shown that there's less loss of local anesthetic through the intervertebral foramina in pregnant women. But it's also been shown in studies that local anesthetic requirements are decreased not just with neuraxial anesthetics, which can at least partly be explained by these anatomic changes, but also other peripheral nerves have an increased sensitivity to local anesthetic. Someone did a study where they found the median nerve was more sensitive to local anesthetic in pregnant patients as compared to non-pregnant patients. And it is believed that this increased sensitivity to local anesthetic also results from the increased progesterone levels that occur in pregnancy. In terms of renal changes, glomerular filtration rate is increased by about 50%, with that returning to pre-pregnancy levels at about 3 months postpartum. Your renal plasma flow increases even greater by 75%, and these changes occur primarily due to decreases in renal vascular resistance. As a result of the increase in your GFR, there's also an increase in creatinine clearance. And what's important to understand when assessing laboratory values in pregnant patients, that as a result of these renal changes, a normal creatinine level in pregnancy is 0.5 to 0.6. It is decreased. So if you get a creatinine level back of 0.9 or 1 in a pregnant patient, although that would be reported by the lab as being within normal range, in fact, that would be considered an elevated creatinine in a pregnant patient. Same with BUN. A normal BUN is about 8 to 9 milligrams per deciliter. In terms of hepatic changes, your transaminases, your LDH are going to can increase up to the upper limit of normal and be considered a physiologic change. However, when they get beyond the upper limit of normal, if they are elevated, you need to start looking for some sort of pathologic source for the further elevations in those liver enzymes. Now, alkaline phosphatase levels can increase as much as 2 to 4-fold due to the fact that alkaline phosphatase is also produced by the placenta. Another important fact to understand in terms of hepatic changes, which is an important enzyme for us as anesthesiologists. It's used for metabolism of succinylcholine, also for chloroprocaine. At term, cholinesterase activity in pregnancy is decreased by about 20 to 25%. Decrease even a little bit more in those first few days postpartum. It's been shown in a study to be decreased by about 33% at postpartum day 3. However, I will warn you that this rarely results in prolonged neuromuscular block with succinylcholine. Succinylcholine is so short-acting, it's metabolized so quickly that 20 to 25% decrease is generally not going to cause a clinically significant prolongation of your neuromuscular block from succinylcholine. So the take-home message here is that despite the decreased cholinesterase activity, I would not recommend decreasing a succinylcholine dose in a pregnant patient. So that's the physiologic changes of pregnancy. Now in this podcast, we're also going to talk a little bit about placental physiology and drug transfer. This is a nice diagram to remind you of the anatomy of the placenta. It is a very complicated organ. Now, in terms of placental physiology, the placenta has some very important functions, has significant hormonal function. Within the placenta, there are steroid precursors that are converted to progesterone and estrogen by placental enzymes. And in fact, by 8 weeks gestation, the placenta is the predominant source of both progesterone and estrogen in the pregnant patient. In addition to these hormones, as I mentioned before, the placenta produces other hormones, including gastrin and also HCG. So significant in the placenta, significant hormonal function. Now, in terms of transport across the placenta, there are a variety of different transport mechanisms used by the placenta depending on what it is that it is being transported from either maternal to fetal side or fetal to maternal side. Passive transport, this is the way, for instance, the oxygen is going to be transported, will occur via passive transfer. So the things that are going to affect passive transfer across the placenta are going to be concentration differences between the mother and the fetus, the molecular weight of whatever's being transported, the lipid solubility, the degree of ionization, and the membrane surface area. So the smaller the molecular weight, the greater the transfer, the more lipid soluble, the greater the transfer, the lower the ionization, the greater transfer. Another mechanism across the placenta is that of facilitated transport, and this involves a carrier-mediated transport of relatively lipid-insoluble molecules along a concentration gradient, and in fact, this is the way that amino acids are transported from the maternal to fetal side. Active transport is another way that some molecules will be transported across the placenta, and with active transport, this requires a protein carrier, and with active transport, the transport will occur against the concentration gradient. And then also there is pinocytosis. This is the way that large macromolecules will be transported across the placenta. For instance, immunoglobulin G is transported this way. So in terms of factors that are going to affect placental transport, there's a variety of factors. One is any change that occur in maternal or fetal blood flow. So, in fact, if you have a mother who becomes hypotensive, that will actually decrease the placental transport of anything being transported to the fetus. This is one reason why you don't want a mom hypotensive, because it will affect oxygen delivery and delivery of other things across the placenta. Placental binding plays a role. Some things that come from the maternal side are bound to some extent in the placenta, and that will decrease the amount of transfer to the fetus. Placental metabolism is especially important for things like glucose. So much of the glucose that goes from maternal side goes to the placenta will be used by the placenta, and that will decrease the amount that is then transported to the fetus. Diffusion capacity is important, and also the degree of maternal and fetal plasma protein binding. So if a drug is highly protein bound on the maternal side, that will decrease the amount of transport over to the fetal side. Now, in terms of oxygen, placental transfer of oxygen, diffusion of oxygen across the placenta is determined by the difference in PO2 between the maternal and fetal blood. Physically dissolved oxygen is the first to diffuse across the villus membrane. Bound oxygen is then released by maternal hemoglobin in the intervillous space and will also diffuse across the placenta. In terms of placental transfer of oxygen, we need to also understand that the Bohr effect will augment the transfer of oxygen, and this refers to the fact that at the same time that oxygen is generally being transported from maternal to fetal side, you have concomitant fetal to maternal transfer of carbon dioxide occurring. So this results in making the maternal blood more acidic and the fetal blood more alkalotic. As a result, this leads to a right shift of the maternal oxyhemoglobin dissociation curve and a left shift of the fetal oxyhemoglobin dissociation curve, and this enhances the transfer of oxygen to the fetus, and this is called the Bohr effect. Now, in terms of placental transfer of oxygen, if you ever looked at the umbilical cord gases that are sent off and looked at the results, you'll note that the fetal arterial PO2 never reaches greater than 50 to 60 millimeters mercury. And so you ask, why is this? Well, part of this is related, as I talked about, in terms of placental transfer of anything. There can be some consumption within the placenta itself. And in fact, the placenta is a very active organ, and it uses a lot of the oxygen that the mother transports to the placenta. In addition, fetal arterial blood is actually a mixture of the oxygenated umbilical venous blood, but also the deoxygenated blood coming from the fetal inferior vena cava. It's important to note that in general, increasing maternal PaO2 over 100 is not going to result in substantial increases in maternal arterial oxygen content because of the shape of the oxyhemoglobin dissociation curve. So, as a result, if you have a fetus with a normal PaO2, increasing maternal FiO2 is really going to have only a slight effect on fetal PaO2 due to the fact that you are on the flat part of the maternal, on the flat part of the oxyhemoglobin dissociation curve. However, if you have a fetus that is hypoxic, you are now going to be, instead of on the flat part of the fetal oxyhemoglobin dissociation curve, you are now going to be on the steep part of that fetal oxyhemoglobin dissociation curve. And in that setting, increasing maternal FiO2 can be beneficial to the fetus in terms of delivering more oxygen to the fetus. So this is why when you see an abnormal fetal heart trace, we will put oxygen on the mother. But on the other hand, if you have a baby that's not showing any signs of hypoxia, is because you're now going to be on the flat part of the oxyhemoglobin dissociation curve, there's really no benefit to increasing maternal FiO2. But in the setting of fetal distress, yes, because you're now on the steep side of the curve, you should consider increasing maternal FiO2 in an attempt to increase fetal PaO2 or delivery of oxygen to the fetus. In terms of placental transfer of carbon dioxide, dissolved carbon dioxide and bicarb are the predominant forms in which transplacental transfer occurs. Gradient, as I mentioned before, favors fetal to maternal transport, and it's important to understand that CO2 readily diffuses across the placenta, much more diffusible than O2, about 20 times more. And the Haldane effect augments CO2 transfer. So what this refers to is the fact that the maternal to fetal transfer of oxygen leads to maternal deoxyhemoglobin, and that maternal deoxyhemoglobin has a greater affinity for carbon dioxide than oxyhemoglobin. So this is the Haldane effect that augments CO2 transfer. So just as you have the Bohr effect augmenting oxygen transfer to the fetus, you have the Haldane effect that augments CO2 transfer from the fetus to the mother. In terms of glucose, glucose is transported across the placenta via facilitated diffusion, but the fetus competes with the placenta for glucose use. Only about 28% of the glucose that goes from the maternal side to the placenta reaches the umbilical vein. The rest of it is used by the placenta itself. What about various transfer of drugs across the placenta? Both the placental permeability and pharmacokinetics are going to determine fetal exposure to any particular maternal drug that has been administered. And there are going to be effects of lipid solubility, molecular size, and the degree of ionization are all going to affect placental drug transfer to the fetus. The more lipid soluble, the smaller the molecule of the drug, the lower the amount of ionization, the greater will be the placental drug transfer. Now, I will caution you that much of what we know about drug transfer across the placenta comes either from animal studies, and you can't necessarily extrapolate because there are interspecies differences that occur, and from just single measurement studies at delivery, so that you know you gave mom a particular drug during labor, and at delivery you draw an umbilical vein specimen and send it off to measure the drug level, and that is where much of our information comes from about drug transfer across the placenta. So we really don't have a whole lot of good hard data about drug transfer. But talking about our various anesthetic drugs that we use as anesthesiologists, in terms of our inhalational anesthetics, there's generally rapid placental transfer due to the fact that these drugs are generally lipid soluble and have low molecular weight. The fetal maternal ratio for isoflurane has been recorded to be 0.71, also high for nitrous oxide at about 0.83. It's been published that the fetal to maternal ratio for sevoflurane is 0.38. Currently, there's no published data for desflurane, but in general, there's rapid placental transfer of your inhalational agents, and this is why you want to avoid a prolonged induction to delivery time. As your induction to delivery time increases, you're more likely to have neonatal depression because there's more time for those inhalational agents to cross over the placenta to the fetal side. And so this is why when you're doing a general anesthetic, usually you prep, drape before you will induce any sort of anesthesia. What about your induction agents? Many of these are quite lipid soluble, and this enhances their transfer. Propofol, anywhere from 0.65 to 0.85 is the fetal to maternal ratio. Ketamine is even higher, etomidate a little bit lower. What about opioids? Fentanyl is highly lipid soluble, but it's also highly bound to albumin, so this offsets the effect of the high lipid solubility. So you have a fetal to maternal ratio that will range anywhere from about 0.37 to 0.57. Remifentanil has a very high fetal to maternal ratio of 0.73 to 0.88. However, you know, as we've used this some in labor for patients who cannot have neuraxial anesthesia, the reason we use it is that there's actually seems to be minimal fetal exposure despite that high F to M ratio. And the reason for that is that it's very rapidly metabolized by the mother, so that there's very little remifentanil available to be transferred. Whatever is transferred, it's a high F to M ratio, but there's not much transferred because it's metabolized so quickly by the mother. Sufentanil has a fetal to maternal ratio of about 0.81. When it's administered epidurally, the lipid solubility of sufentanil results in it being rapidly taken up by the CNS, however, and therefore that reduces both on maternal umbilical vein concentrations and fetal exposure. So it's more of an issue when it's given systemically rather than epidurally. And that would be to some not as much of an extent, to some extent with fentanyl. When it's given neuraxially, there will not be as much of an effect as when given systemically. Morphine has a very high F to M ratio. Meperidine also has rapid placental transfer with an F to M ratio greater than 1. It's important to understand that the peak fetal levels, if you're giving Demerol to a mother, are going to be at about 2 to 3 hours after maternal administration, and this can lead to significant neonatal respiratory and CNS depression at delivery. So be mindful of that. If you're going to give Demerol, you should only give it if you think mom's going to be delivering within an hour, or if you think it's going to be several hours later that she's going to deliver. You want to avoid giving it at such a time that in 2 to 3 hours the baby's going to be delivered, because that's when your peak fetal levels are going to occur. Butorphanol has a fetal to maternal ratio of about 0.84, but just like in the mother, there's a ceiling effect on the neonatal depression caused by butorphanol due to its agonist-antagonist properties. What about our local anesthetics? Lidocaine has an F to M ratio of about 0.5 to 0.7. Bupivacaine significantly lower, about 0.2 to 0.4. And this is because bupivacaine is very highly protein bound in the mother. So that is one advantage of using bupivacaine, is that you'll see less placental transfer. Ropivacaine has a fetal to maternal ratio similar to that of bupivacaine. Now, one thing to talk about with your local anesthetics and placental transfer is the effects of fetal acidosis. So if you have an acidotic fetus, what can happen is the phenomenon of what we call ion trapping. And what this means is that any of the local anesthetic that does cross over to the fetal side, in the setting of an acidotic fetus, more of that drug is now in that acidotic environment going to enter into the ionized form of the drug. Ionized form cannot cross the placenta, so that can then lead to fetal accumulation of local anesthetic and ultimately can lead to a floppy baby at delivery. And this is one of the main reasons why we prefer to use chlorprocaine in the setting of non-reassuring fetal status or signs that there's fetal compromise, because chlorprocaine is metabolized quickly on the maternal side by plasma cholinesterase. So there is minimal placental transfer of chlorprocaine, so you do not have this ion trapping effect that you will have with your other local anesthetics in the environment of an acidotic fetus. In terms of placental transfer of muscle relaxants, these drugs are all fully ionized quaternary drugs that do not easily cross the placenta, so there's a very small amount of placental transfer, and it would be extremely rare for muscle relaxant given to the mother to have any sort of adverse effects on neonatal muscle tone. In terms of the placental transfer of muscle relaxants, the result of this, as I said, very limited. F to M ratio for your non-depolarizing agents is about 0.1 to 0.2. In terms of succinylcholine, generally, in the normal fetus, you are not going to see detectable fetal levels of succinylcholine until you get to maternal doses of 300 or greater, 300 milligrams or greater, which is not a dose that we would use in a patient. Now, there are situations where you could see some neonatal neuromuscular blockade occur with succinylcholine. One would be the very rare situation where you're giving large repeated maternal doses. I've never seen that done. But the other one to think about is in the setting of a neonate who may have atypical pseudocholinesterase. You could see some effects of succinylcholine in the fetus in that situation. And then finally, what drugs do not cross the placenta? Large drugs, large molecules are not going to cross the placenta. Insulin, heparin are the two that are important for us to understand do not cross the placenta. And so that's a bit of a summary of drug transfer in terms of at least the drugs that we as anesthesiologists generally are using. And so that concludes this talk on physiologic changes of pregnancy and placental physiology and drug transfer.